Thank you, Steve. So yeah, we've heard about a number of different organs, and you're going to say, well, parathyroid, what's he talking about? So let's talk a little bit about the why first. Well, autotransplantation has been happening for some time with respect to parathyroids. So in ENT surgery, head and neck surgery, where the thyroid gland is removed for cancer, for example, you can then preserve some of the parathyroid tissue and autotransplant on the same patient, usually in the forum. And in renal failure, indeed I do all the parathyroidectomies here. You can do either a total parathyroidectomy or 3.5 gland parathyroidectomy, and that other half you can either leave it in the neck or cut in small pieces, put in the forum to try and preserve some parathyroid function. So some of these things have been going on for many years. What about allotransplantation? Well, when you look at the literature, there is some work, but usually very small numbers with respect to this topic. So in this particular paper from Turkey, they took 4 donors. There were patients with renal failure. They had hyperparathyroidism. They did 3.5 gland parathyroidectomies, and then took some of this tissue to produce cells and cryopreserve them, and then transplant them in different recipients. And they used some steroids at the time for a short period, and 7 out of 10 recipients showed successful function. And you can see here the PTH going up and staying up in these cases. But these were not associated with any kidney transplantation. And one of their arguments was that the parathyroid cells do not express class 2 antigens, and therefore rejection is not necessarily going to happen. Now, so the reason to do it is for patients with hypoparathyroidism. And I'm going to sort of take you through the argument. So there's a number of causes of hypoparathyroidism, as you can see. I'm not even going to attempt to go through all of it, but some autoimmune disorders, genetic disorders, resistant to PTH action, and drugs, just to summarize a little bit. So I'm going to talk a little bit more about autosomal dominant hypocalcemia, where essentially you have low calcium and inadequate parathyroid secretion. And ADH, there's ADH1 and ADH2, and there's different mutations for the two. But I'm going to concentrate more on the calcium sensing receptor gene mutation. And when you have ADH accompanying with hypocalcemia, kalemia, and metabolic acidosis, you can call that type 5 Bardet syndrome. And there are 5 such syndromes. You've got the most severe ones that are antenatal, and those are the 1, 2, and 4. And then the postnatal, the more classical ones, and a little bit less severe, but still debilitating, that can occur later on in life. So the issue with the particular Bardet syndrome, the 5, you've got an intrarenal defect here, the thick ascending limb of the loop of Henle. Normally, the calcium sensing receptor inhibits sodium transport, and the active mutation leads to salt wasting. And essentially, you have low PTH, high salt loss, and hypercalciuria. If you want to know the details of the in receptor pathway, you can read this. I don't know it, but essentially, you get low PTH and high urine calcium. Symptoms, well, in the most severe condition intra-pregnancy, during the pregnancy, you get polyhydramnios. You can get failure to thrive. You can get, as we said, loss of salt in the urine, and therefore polyuria, constipation, dehydration, as we said, the hypercalciuria, and issues with nephrocalcinosis, and also the low calcium and its effects as described here. So I want to tell you about a patient M, who started at grade almost 3 and ended up in Evelina, so you can say joint care at different time points. So she was born in 2007. She was 37 weeks at the time, the gestation, and there was polyhydramnios. Did well to start with, but at 7 months presented with polydipsia, polyuria, convulsions, and hypokalemia. Also, the magnesium was low at the time. And she had genetic testing and diagnosed with Bartter's 5. And she had nephrocalcinosis. Initially, she was managed with alpha-hydroxycalciferol, but 1 year later required a subcutaneous PTH pump. And at times she had low calciums and needed extra calcium supplementation. At the age of 10, she had end-stage renal failure, and eventually she needed hemodialysis, which started, I think, a little bit later. Yeah. Anyway, she had some metabolic bone disease as well, and she needed bilateral hip pinning. And I think it was Leslie originally who referred her to me saying, what about doing because at the time she didn't have a live donor, what about doing a deceased donor transplant as well as a parathyroid transplant from a deceased donor? So I was in the process of writing to our NHSBT body that regulates transplantation here and sends us kidneys, but never parathyroid glands, to ask for one. But then she was transferred to Evelina, and her dad wanted to donate a kidney. So we spoke to the dad, but before that we did some Medline search to see what's going on around the world. Well, there isn't much basically, but this was the best paper we found from Enrico Benedetti from Chicago, who some of you may know. He does a lot of robotic donor nephrectomies and transplants, again robotically. So he did take a parathyroid gland robotically and wrote it up. So this was from a live donor. But before that, he reviewed the literature as well and found a few cases where the parathyroid gland was transplanted in some way or another. But what we've highlighted here in red are the cases where there was a kidney as well. And most of those were sequential, kidney and some parathyroid tissue. There was one simultaneous deceased donor kidney and parathyroid gland. And the case that they described was one of simultaneous kidney transplant and parathyroid gland. And the recipient was a 23-year-old. The donor was 25. And you can see here, following transplantation, the PTH level going up. So the synthetic PTH is not registered by the lab. So you can nicely document the function of the parathyroid gland when it does happen. And of course, it's a vascular tissue, so it doesn't start working straight away. And it can be up to a month later on when you start getting some function. So the father was 43, and he accepted to have one of his parathyroid glands removed. So did the nephrectomy first, standard hand-assisted technique, and then I decided, well, I had already planned that I would take the right upper parathyroid gland. The reason I chose an upper gland was that 80% of the time it's a constant location where it will be, whereas the lower one is only about 60% and they're at the same place. So I thought it would keep things simple. Also did a frozen section afterwards to make sure it was parathyroid gland. Just in case it didn't work, I didn't want people to say, well, maybe you just implanted a lymph node or a bit of fat. So proved that it was parathyroid. And then we've sent the kidney first across. Nizam started the transplant. Then I took the parathyroid gland out, put it in a similar big box, which is kind of funny because the gland was about that big. The box was that big. And transferred it across by ambulance. And the cold time was 5 hours for the kidney and 7 hours for a parathyroid gland. And I'll show you how we did the parathyroid gland, essentially. We divided it into multiple small pieces. So that's the donor on the parathyroid gland there. Okay, that's the neck. That's the intraoperative location of the parathyroid. Took it out. It was about 11 millimeters, a little bit of fat associated with it. And then at the recipient side, we cut it into multiple pieces. It was about 11, I think. And then open up the. So this was the same incision Nizam used for the implantation of the kidney. So radial fossa, but I've asked him to save the rectus muscle for me. So opening the rectus muscle and implanting a bit of parathyroid in the muscle, and then securing it with Prolin, but also putting some LICA clips in case we need to radiologically find where the parathyroid tissue is in the future. So you can see the kidney transplant here, and that's the parathyroid transplant essentially. And this was the first one done in the UK, as well as the first donor of a parathyroid tissue in the UK. So kidney functioned immediately, and then every day we kept checking the PTH to see when the parathyroid gland will start working. So eventually it did start. I think it was about day 8. We had the first hint of the PTH going up, and it was always since 2009 going back. She's always had just single figures of PTH, but for the first time she started having 2 figures, as you can see, 20s, and so on. Obviously, she's been under the care of the endocrine team at Evelina as well, and they slowly reduced the PTH pump. Happy to say that she came off that in 2019, and she's been on that pump just like a diabetic for about 10 years before. And you can see here, that's her creatinine, and this is the PTH, so undetectable before and since the transplant. So, living donor, parathyroidectomy and parathyroid transplant is feasible. And of course, when you combine it with the kidney, you don't need any extra immunosuppression, so that solved that problem. Our results so far are satisfactory, and I must say, I needed about 1,000 emails before to get the process done. I needed approval from NHSBT, from the Human Tissue Authority, from the governance team here at Guy's for the donor, as well as for the recipient at Evelina. Thank you very much.
Thank you very much indeed, Nicos. That was excellent. Whilst people are thinking of questions, what do you think the longevity of the graft is? Does it get vascularized and then unlikely to have rejection is going to work for the next 10, 20? Do we know?
Well, we don't know. But Natalie's writing the case report, but maybe in 5 or 10 years we can write the next case report and say what happened. Hopefully it will last forever. Okay, well, I read the literature, and then essentially it said anything between 1 to 2 millimeters, and I cut about 1.5 millimeters. Good point. It's just that if one dies, then I have 11 options as opposed to, I don't know, 3 or 4, I guess. Just what I could find. There's not a lot of literature, as you can see. Yeah, Vlad.
Nicos, excellent piece of work. Congratulations. A couple of questions. First of all, would you consider parathyroid after kidney, for example, for somebody who lost parathyroids for whatever reason before?
From the same donor?
No. Just from UK transplant, delivered small piece in big box. And second question, God forbid there is a hyperparathyroidism in those bits which you divided so spread so evenly. How are you going to chase them later in the muscle?
Okay. I'm sure I'll forget the first question, but to answer the second question first, you've seen a marked where the tissue is. So there's 11 pieces of proline there. That's not absorbable, and clips. So radiologically, I can even mark the patient before I have to go and remove the tissue, for example. And then inside, I will see the clip and the prolin and remove it. So, I mean, there are reported cases where for autotransplantation, for example, where there was a need to go and remove it. So that's why I marked it before. And the first question, well, the issue is it depends on the case and the reason why would you want to go and do parathyroid transplant in your case that had a kidney transplant. So as most of our patients will have already parathyroid glands, unless they had congenital agenesis, which was the case from Chicago, for example. Most patients will have adequate parathyroid function, if anything, be more, of course. So that you need to define the case. In those cases, probably not many. Yeah. Yeah.
Okay, thank you very much indeed. You'll be pleased to know that we're now back on time schedule-wise, but for those of you that are looking at the programme, especially those that are doing the live streaming and in Armenia, we apologise that we're going to delay our coffee break because Nicos is going to continue to speak and he's going to do his later talk earlier now, so he's going to tell us how to increase living donation for paediatric transplant recipients.
Okay, so this time I'm going to talk about how to increase living donation for pediatric recipients, or at least my view. So first of all, I thought we'll review what goes on in the UK. Obviously, I'm biased from that point of view. And this figure shows the number of living donor kidney transplants that happen in UK. So from 2004 to 2018, and you can see the trend. Obviously, at the introduction of the laparoscopic life-donor nephrectomy program through minimal invasive techniques, the numbers went up and then they plateaued. When you look at the figures from the US, the same increase happened, but after that there's been a decline. So what can we do? Well, first of all, we need to see and analyze that graph a bit more. So what are the type of donors that we have? And this figure shows dark blue the related transplants, and the trends, the unrelated, the light blue. So that's gone up a bit, as you can see. Also, the antibody-incompatible transplants, HLA is the white, and ABOI-incompatible, the slightly gray. So you can see the numbers had gone up, but those have been going down the last few years. But what has been going up and stayed up is the pair exchange and the altruistic donor numbers. So I could conclude my talk by saying that's what we should do, but I'll talk a little bit more. So what about, that was for all donors, and what about pediatric living donors? And you can see the numbers here. So we're definitely doing more living donor transplants now than in the 2000s. And again, you can see that a percentage of that has been through the altruistic pair exchange as well as incompatible. And the incompatible, again, you can see the same trend, slight increase in the numbers, but then decrease as we've been pushing more and more of these donors, the incompatible donors, through the pair exchange scheme. And here, this shows, according to the unit, the type of donors and transplants. So you can see that the majority are related donors. So we should definitely try and find more unrelated donors, I think, family members maybe. But you can see again the antibody incompatibles a tiny bit, and pair exchange or altruistic. Since our well, for whatever reason, I sense that there's a bit more pair exchanges these days coming through. So I think that program will definitely develop more as time goes by. And these are the last year transplants, and you can see the numbers. Manchester 19, we've got Manchester representation here. Evelina and Guys 9, and Gosh 13, and of course we've got the same searches for those two hospitals. But to put that into perspective, I thought I'll show you the deceased donor list and how many patients are waiting. We have got about 128 patients there, but of course, about 36 are suspended. So that's the number of transplants done in the UK, more or less. So a little bit about IBI and HLA-I. I know we touched a bit on the subject before. This graph is specifically for that. The light blue is the ABIs done per year, the last 10 years or so. HLA-I are the dark blue, so obviously less than the ABI. And just one HLA-I ABI in 2013, 2014. So not huge numbers, but still they contribute to the donor pool. And here is where these incompatible transplants have happened. You can see the majority have been at Gosh. I think Steve is writing that up, if I'm not wrong. Yeah. So we wrote our experience for ABI, Anna, who's somewhere in the crowd, and Yelena. So Yelena, the ABI, and Anna, the HLA-I. So we'll talk a little bit about that. Essentially 11 ABI recipients that we're describing here, and our protocol is this. So essentially it depends on the titer of the recipient. So if it's less than 8, we don't do anything, we just proceed cautiously. If the titers are 8 or above, we give rituximab. And then if it's 16 to 32, we use double filtration plasma exchange to bring the titers down to equal or less than 1 in 8 before proceeding to transplantation. And if they're more than 64, we use the Glycorex columns from Sweden, which are very expensive, as you know. So these are the demographics of those 11 cases, and they were compared with 50 compatible transplants. And just to summarize, the graft survival was 98 versus 100% in the compatible versus the incompatible. Essentially similar results, and the rate of rejections, so 24 versus 9 again, respectively. And this is just to show you briefly the baseline titers where we started before any immunoabsorption or double filtration plasma exchange. And you can see the maximum was 128. And for those who do adults, you know that we do a lot higher dose titer levels for adults. And the results of rejection-free survival were similar, essentially, not significantly different. And this was the first 2 cases of HLA incompatible transplants that were done at Great Ormond Street. Since then, in my recollection, we've done another 2. But anyway, to answer Andrew's question from the past, one was from abroad. Anyway, the results were, again, were very successful. The first case had ATG, the second case had Campath, but just that reflects our adult program that as we change with time. And you can see here the DSA level on one side, and the creatinine in the black line. So creatinine came down nicely, but the antibody level came up, stayed up, but luckily with no rejection or deterioration of graft function. So the way we do the HLA-Is is we do what's called a test plasma exchange. So we have one session of double filtration plasma exchange to see how successfully the decline in the antibody level will be before we can plan how many sessions they will need of reduction of antibody through the plasma exchange. And as I said, we give Campath these days. But pair exchange is where we push more, both for our adult and the pediatric program. So we talked a little bit about the kidney sharing scheme. Since we've got an international crowd here, just to say that the law changed in 2006 to allow us to do these. The first run was in 2007, and short chains and longer chains were introduced later on. So the standard 2-way exchange, 3-way, and nowadays short chains or long chains up to 3. And sometimes we don't do them all in one day. Very briefly, just to say that some patients, some pairs stay in the list for a long time, And these are the extra added cases every time there is a run, and there are 4 runs a year in the UK. And the majority were HLA incompatible for the ones that were registered, and 34 ABOI. And the last few years we've been adding compatible pairs as well. And from all those cases that went through the pair exchange scheme, 65% the transplants proceeded. And you can see how the altruistic donors have contributed in the increase in the number of successful transplants as time went by. And again, this reflects the fact that there's an increase in pair exchange and altruistic donation as the years went by. Nizam is going to talk about transplanting the untransplantable, the ones with no IVC or aorta. And of course, they increase the pool by having a live donor. Of course, you still need to have a live donor. So here we present about 5 cases, Pankaj's paper, on these complex cases. So the child with no aorta, actually there's a bypass there, and here no IVC. You can just see the left gonadal vein going into the left renal vein, and essentially we use that gonadal vein and the aorta at that point to do the transplant. Nizam did the transplant, I did the donor. And again, Pankaj's paper that describes a novel classification system. So you've got aorta and IVC, A and V respectively. A1 and V1 are entirely normal vessels, and as you go down, they become occluded completely to A4 and V4. So this particular case, you can say, was essentially an A4 and V4. Again, I'm sure Nizam will talk a bit about this, but you see the 3D printed models there. So this is like an adjunct to allow us to do more complex cases as well. Now, we briefly touched on social media before. We did a survey through the European Society for Organ Transplantation, and we had some 190 responses, and these were mainly clinicians. And essentially, social media, as we heard before, is a way of increasing potential donor pool, and there's a number of benefits that I'm going to touch in a moment. But for example, this you may have heard, some of you, what's called organ mines. Essentially, they produce these nice-looking different organs where you can discuss and teach kids, with the hope that they will grow up eventually and they will know that it's the norm to do transplantation and donation. Because at the moment there's no curriculum in the schools to promote or teach about organ donation. So that's sort of looking at the longer term, essentially. So benefits, well, there were a number of benefits, but working prospectively and retrospectively to try and encourage donation through using different cases that happened in the past, different campaigns, using the Kidney Patient Association as well to help. And I want to show you this particular case that somebody mentioned earlier on. So this is Ethan. His parents put an advert on Facebook, and we had to stop at 20 because it was just getting a bit too much work for our coordinators. And you can see that's the donor. She's in her 20s, and they only met once before the actual donation. I did his transplant, and before I could go home, his picture was on Twitter, that evening. So a lot of the stuff we do now is in the media, but putting that aside, you can see how you can increase the donor pool. We heard that you can get up to 100 potential donors So that is happening. I think with time we were a bit resistant or didn't really know what to do in the UK. But as we've been discussing with the Human Tissue Authority over the years, we've become a bit more relaxed with this. I mean, obviously there's a lot in the USA as well on this. And as long as there's no money exchange, essentially, we can proceed. Another way is using collaborations. And Nizam has been to Armenia in the past and done a few transplants there, hence the Armenia connection through the video link. But we've also been to Serbia more recently. And you can see in Belgrade, their live donor rate went down when they lost their surgeon. There, went to 0. So we went along and tried to teach Vlad over there to do both live donor nephrectomies as well as transplants. So we've done 3 so far. And you can see, you'll never see this in the UK, but there were 3 nephrologists in the theater at the time. And Sanya is with us today as well. And we've managed to increase the rate there. So every little counts. So we talked a bit about incompatible transplantation, the sharing schemes, transplanted complex cases, and Nizam will talk a bit more about that in a moment, the use of social media and collaborations. Thank you.